Okay, so we're going to be talking about heart failure, and I had already made a bunch of notes, so I'm going to be kind of copying and pasting. So I probably should have labeled the page. We're going to be talking about heart failure. And so let's review like what the normal heart is like. So I'm going to copy this over. One moment. And we shall paste it. Okay. So the normal heart, or what we can consider normal, since apparently we don't have a normal, the normal heart has four chambers. You have the right atrium, the right ventricle, the left atrium, and the left ventricle. And if you'll note, and I'll grab a different color, if you'll note, based on my really crude drawing, the left ventricle muscle is a lot thicker than the right ventricle muscle. And remember, that's because the left ventricle has to combat, like the blood has to go out to the body, and it has to combat systemic vascular resistance. So it has to be stronger. Whereas the right ventricle, only has to go to the pulmonary system, and this one's combating the pulmonary vascular resistance, so PVR, and basically that's just the pressure that they have to combat. So with systemic vascular resistance, things like hypertension, or high blood pressure, hypertension, that you can think of that like that's a higher pressure that the left ventricle is having to overcome. So hypertension, vasoconstriction, which can happen like with shock or like shock, like distributive shock, or fluid loss, like based from trauma or something like that. Those things can cause increased SVR, or just dehydration, just not enough fluid in the body can cause that. And then pulmonary vascular resistance, this is normally a much a lower pressure. That's why this ventricle doesn't have the increased. It's not that muscular. So the pulmonary vascular resistance is usually lower, but things like pulmonary hypertension will cause an increased pulmonary vascular resistance. So the normal EF of the heart is usually 65 to 70%. The heart will never be normal EF is never going to be 100%, because the heart is always going to have some blood in it to keep it from collapsing in on itself. And normal cardiac output for an adult is 4 to 8 liters. Now that can be, that depends on a lot of different factors, but normally 4 to 8 is normal. Now you also have to think about, there's another thing that like with cardiology we look at, and that's the cardiac index. And what the cardiac index is a measure of the cardiac output and the body surface area, so what we do, and there's a whole formula I'm not going to go into, but basically what they're looking at is, let's say that, your patient is a 300-pound, 6'7" male, and their heart is only pumping out 4 liters of blood. Well, their cardiac index is going to be low, even though their cardiac output is normal, because their body requires more output. Whereas if you have, a 5', 100-pound female, a cardiac output of 4 is normal. So they would have, their cardiac index would be normal with 4 liters of cardiac output. So that's just things to think about. So they might have a normal cardiac output, but based on their body surface area, it might not be sufficient for them. So then I'm going to go back, and I'm also going to grab the thing that I did about the normal. Well, actually, I'll just draw the normal circulation. So this one here, this is normal circulation. So this is how the body normally works. So let's start with the deoxygenated blood. So deoxygenated blood. And of course, we know that this comes from the body. So that flows into the superior and inferior vena cava. And that goes into the right atrium. Okay. The right atrium then brings that blood to the tricuspid valve, which then flows the blood into the right ventricle. Okay. From the right ventricle, we're going to go to the pulmonary artery. Now, with the pulmonary artery, normally arteries carry oxygenated blood. An artery is anything that goes away from the heart, or any vessel that goes away from the heart. Veins go towards the heart, and so normally, your arteries are carrying oxygenated blood. The only time that this is not the same is in the pulmonary system. So the pulmonary arteries will carry deoxygenated blood from the right ventricle to the lungs. And I'm gonna to the lungs where it gets oxygenated. So that's why I kind of did this, this gradient there. Then the lungs carries the oxygenated blood to the left atria, which goes through the mitral valve, and then to the left ventricle. The left ventricle then pumps blood to the aortic valve, or through the aortic valve, and then the aorta. And the aorta is then distributes the blood all the way to the body, so all of our capillaries, all of that good stuff. And then we circulate, so we're going to get, our oxygen's going to get used up, and that's how we're going to get, this mixture in the capillary beds of oxygenated and deoxygenated blood. And then the veins are going to bring the whole thing back again. So that's the normal circulatory system. Things like hypertension, normally hypertension is the biggest one, but it causes an increased pressure right here, which can then lead to and I'll do this in a different color, I'll do it in black because it's not good. It can lead to a backflow of the system, which is what eventually causes heart failure or chronic heart failure. Acute heart failure is a different thing, but chronic heart failure will happen because of this backflow. So now let's talk about it. So there's two types of heart failure. There's left-sided and right-sided heart failure. So, and I know I said something about this in the one of the patho lectures, in the cardiac one, but so left-sided heart failure, there's two types of left-sided heart failure. So there's two types, and this is normally when we look at the EF. And I think, let me see the notes that I had written here. Yes. So with left-sided heart failure, the symptoms that you're going to get for this, so let's look back at our circulation, okay? So let's look back at our circulation. Left-sided heart failure, we're talking about this left ventricle, okay? So what does the left ventricle back up into? it backs up into the lungs, right? So your symptoms for left-sided heart failure are going to be mostly, let's do a different color. Let's do this one. Symptoms are going to be mostly respiratory. Okay, so this is when you're going to have crackles, cough, pink tinged sputum if it's really bad. You're going to have decreased exercise tolerance, and I'm a terrible speller, exercise tolerance. You're going to have dyspnea, orthopnea. You're going to have wheezing. My respiratory therapist loves to inform me not all wheezing is respiratory related. It can be cardiac related. You'll have paroxysmal, nocturnal, nocturnal dyspnea. And normally we're going to have also fatigue here because they're not getting oxygenated correctly. You can also see signs of cyanosis and poor oxygen perfusion. So you might see, poor cap refill, low pulse ox, that kind of stuff, because these patients aren't getting oxygenated. Their ABG, well, we wouldn't do ABGs in primary care, but your ABGs would be messed up, that kind of thing. So that's your symptoms. And remember, these are respiratory because, like I said, the left ventricle backflows into the lungs. So when you're thinking of heart failure, think about backflow. So think about the fact that the blood is something's failing in the heart, right? So that's why it's called heart failure. Something's failing in the heart that it can't go the way it's supposed to go, right? So it starts to backflow. So anytime you think about it, left ventricle, yes, it pumps into the body, so you would think body symptoms. No, think about it's backflowing, okay? So that's left-sided. So let's talk about the two types of left-sided heart failure. So the first type is systolic or reduced ejection fraction. Okay, so systolic or reduced ejection fraction. Now I'm going to take my little drawing from over here because I made a little drawing for it. So I'm going to take my drawing and I'll copy it over and paste it. Okay, there's my drawing. And I'll increase it so you guys can see it. Okay, so with systolic or reduced ejection fraction heart failure, what's happening is that this ventricle, so think of a rubber band, right? So let's draw a little rubber band here so you can see it. The little rubber band is all stretched out. So remember, I don't know if you guys ever played with rubber bands. I did. You can stretch it and stretch it and stretch it, and you could stretch it to a point and it would always, return back to its original shape. But when you stretched it too far, it would never return back to its original shape. It loses its elasticity, it loses its ability to hold things. Same with a balloon, right? You blow a balloon, if you blow a little air into it, it'll go back like new. But if you overblow it or overfill it, you're always going to have that stretched out balloon. So that's what happens with the left ventricle in systolic heart failure. So basically, all this blood's been backing up into it, and then this muscle just becomes weak, and it starts to grow, and it starts to dilate. So this is actually called, this example right here is dilated cardiomyopathy, which is the most common form of systolic heart failure. So again, remember, let's think back to A and P. Systole, and I'll do this in a different color. That's a terrible color. Excuse me. Systole is the pumping of the heart. So when we have systolic heart failure, we have pumping problems when we have systolic heart failure. Okay? So what happens is it's dilated. So remember, and now remember how I said that the normal cardiac output is 4 to 8? And of course, I'm not saying that the heart's actually taking 10 liters. I don't know how much actually is in the heart. This is just an example. So what happens is that because it's dilated, there's more room here to fill. So this heart starts to fill more. And because this muscle is weak, it's not able to contract. It loses contractility. So we have decreased contractility. So our EF is decreased, so our ejection fraction is decreased. Ejection fraction is the percent of blood pumped, okay? So if we have 10 liters, most people, well, anyway, I'm not going to go into that. If we have 10 liters of blood and our heart's weak and it's not pumping effectively, then we're going to see EFs like 20 to 25, 40 to 50, that kind of thing. So it's reduced. And the reduced EF is actually saying, what it actually means is that there's a reduced cardiac output, right? Or an insufficient cardiac output. So our patients have some I forgot my train of thought. We have decreased cardiac output. So these patients are not getting the adequate output to meet the needs of the body. So our organs are not getting perfused correctly. That's the biggest problem. And that's why patients with heart failure have so many comorbidities: kidney disease, respiratory problems, diabetes, anything like that, because liver dysfunction, because their organs are not getting properly perfused. A lot of them get like encephalopathy because their brains are not getting perfused correctly, and all that kind of stuff. But I'm getting ahead of myself. So then let me go grab my other little picture for diastolic heart failure. So diastolic heart failure compared to systolic heart failure. Diastolic heart failure is also called preserved ejection fraction. And let me paste my little picture. Paste. And make it bigger. So diastolic is called preserved ejection fraction. These patients are going to have, if their EF is not normal, it's going to be close to normal. So it'll be like 60 to 65, 55 to 60%. So, you'd be like, oh, okay, that's good. That's the one you want to have. Well, actually, what happens with diastolic heart failure, and in this picture, I've drawn the most common type of diastolic heart failure, which is caused by ventricular hypertrophy. And the reason that this happens is because, again, think back to our circulation. This SVR, remember I said that the SVR increases. I set it up here. The SVR increases. So, the body can go one of two ways. It can either dilate because the blood's backing up into it, or the muscle will start to hypertrophy. So if you note here where I've made this little marking, you see how this muscle is so much more enlarged than the regular normal muscle. So what happens is the cells start to hypertrophy in an attempt to overcome this increased systemic vascular resistance. So yeah, that's why it happens, and that could be caused, to most of the time it's because of chronic hypertension, but there are some genetic abnormalities that can make patients have ventricular hypertrophy. Another thing, and it's probably going to be on the test because they always like to talk about this, is ventricular hypertrophy is the number one reason for young athletes to die. So they have this problem, and because their EF is normal, they don't really have any symptoms. They're young athletics, they're healthy kids, this and that and the other, and then they're doing these intense exercise regimen, and because they're not getting enough cardiac output, they get what we call sudden cardiac death. So anyway, that ventricular hypertrophy is the number one reason why young athletes, young healthy teenagers, die suddenly. So you're probably going like, okay, so she said that their EF is normal. Why are we worried about them? So because this muscle is enlarged, do you see here how there's like no room for filling? So we're only filling, and again, this is just an estimate, we're only filling like 2 liters in the heart. And remember I said that normal cardiac output is 4 to 8. So we're pumping out a good amount. We're pumping out 60 to 65, but 60 to 65% of 2 liters is not an appropriate cardiac output. So these patients are, again, having decreased cardiac output, insufficient cardiac output. They're not getting perfused well. They're not getting what their organs need. So that's diastolic versus systolic heart failure. So the causes, and I've touched on these a little bit, and I'm just going to pull it from over here. The causes of this one, let's see, I'm going to grab this. Let's copy it. Let's copy it over. Paste. So the causes of this one are, the main cause would be systemic vascular resistance. So this is chronic hypertension, vasoconstriction. So like I said, the ventricle works harder to pump against the increased pressure, and 2 things can happen. They either hypertrophy to increase the contractility, or the blood backs up, overstretches the ventricle, and dilation occurs. Genetics is also another one that can cause this. So a lot of patients, genetics, or they can have like genetic diseases is what I really meant. So with genetics, a lot of patients, I've had a couple of patients that have like a muscular disorder. So, and I can't think of the name right now, but basically what happened is that their muscle tissue proliferates too much, and they have to be on chemo and all kinds of stuff, but it's an autoimmune disorder, so they're not going to get any better. Drugs. Now, drugs is the biggest, especially cocaine, is the number one reason why we see young patients with heart failure. And now I'm not talking about the young athletes that had, ventricular hypertrophy because of a genetic disorder. Cocaine is the number one reason why we see, cocaine and drug use is the number one reason why we see young 30-year-olds with this crappy EF, because cocaine increases the blood pressure, vasoconstricts, increases heart rate. It basically functions, it's a stimulant, but when people do it too much, that their heart just gets weak after a while. The heart does not like to pump. Like, the heart does not like to be, above its normal rate of 60 to 100 for very long. And it doesn't like high blood pressure. The heart is very finicky. It tires easily. lately we've been seeing a lot of patients post-COVID. One of the post-COVID symptoms is like viral endocarditis, and that can cause heart failure because the structures inside the heart are damaged, and you can get like stenosis of the valves and things like that. So the blood is not being able to be pumped effectively. It's backflowing because the valves, when the valves close, it prevents backflow. That's one of the main functions of the valves. So the valves, heart valves, prevent backflow of blood. So if the valves are not working effectively, then we get backflow, and that's basically what causes heart failure. It's just backflow. So bacterial and viral infections are a big reason for young people as well. So bacterial, it could be like a lot of staph. Staph is really what causes the bacterial endocarditis. MRSA, if they've ever had rheumatic fever because they had a so staph, which is MRSA, rheumatic fever, also called scarlet fever, and this is usually post strep infections. That's really what causes bacterial infections. Sometimes, that could be post something like this, or it could be an introduced infection that we gave them, like when we do pacemakers and stuff like that, or any kind of cardiac surgery. And shock. So cardiogenic shock is actually a form of heart failure, but it's normally acute, and it can be reversible as long as we get to it in time. So shock is actually a form of heart failure. These patients have really crappy EF because they don't have blood flow, like they don't have enough blood in the system. Things are dilating when they should be constricting, and constricting when they should be dilating. Like it's a whole mess. We have to play a lot of times. People with cardiogenic shock, they have to be placed on like in a balloon pump and things like that to help their hearts pump. So I've already talked about the symptoms of heart failure. I've already talked about the causes of heart failure. Diagnostics, and this can be diagnostic for both left-sided and right-sided heart failure. So let's do that in a different color. Let's see. Let's do this like orangey. So diagnostics. So labs. BNP is one of the big things that we look at, the basic brain natriuretic peptide. So what BNP does, so BNP is the brain natriuretic peptide. And this is a natural, this is the body's natural diuretic. Okay, so this is released when the ventricles overfill. So the body loves homeostasis, as we all know. So when the ventricles start to overfill or start to stretch because there's too much fluid in the body, the heart ventricles, when the heart starts to stretch, it sends out basically distress signals to the brain and they're like, hey man, release the BNP. We need help. So the BNP is released, and it basically stops the kidneys from reabsorbing water and sodium. So it makes you pee. So that's one of the things that we can look at with heart failure. We can also do like EKGs, you might be able to see some differences with the EKGs. So EKG with a chest X-ray, you're gonna see a large cardiac, and I cannot spell silhouette. Okay, you know what I'm trying to say. A silhouette, or basically just an enlarged heart. You might be able to see, if it's left-sided heart failure, you'll be able to see pleural effusions, or edema. And then our biggest diagnostic test is our echocardiogram, and this is, you can't diagnose heart failure without an echocardiogram. All of these things, they can be indicative, but an echocardiogram, this is the gold standard. So this is where you can see a lot with an echo. You're going to see the structures of the heart with the echo. You see the structures of the heart. This is when we get to see what the EF is. This is when we get to see if there's any dilation in the ventricles and if the valves are working properly, anything like that. So the echocardiogram is the biggest, and this works for all these diagnostics are the same for both sides, left and right-sided heart failure. So now let's talk about right-sided heart failure, and it's not going to be, the biggest thing with right-sided heart failure is the symptoms. This is what you have to remember, because right-sided heart failure is what you think of when you think of heart failure symptoms. So the symptoms for the right side are going to be body symptoms, okay? Now think back to our flow here, okay? So right now we're in the right ventricle, right? So where does the right ventricle flow back to? The body, right? So all this blood, all this fluid is going to back up into the body, because heart failure, like I said, is just a reversal of the circulation system, of the circulatory system. So this is when you're going to see JVD. This is when which is jugular venous distension. This is when you're going to see edema. This is when you're going to see JVD, edema, a lot of weight gain. Now, with weight gain, we always tell our patients, if they gain 2 pounds in one night or one day, or 5 pounds per week, they need to call their doctor, because they need to go get evaluated. You might see, with both left and right-sided heart failure, you might see nausea, anorexia, that kind of thing, just because they don't feel well. These patients with right-sided heart failure might also feel fatigued because they're carrying around so much extra weight. They might have dull pain in the right upper quadrant because of hepatic congestion, so it's flowing back into the hepatic system. That's called portal hypertension, when those hepatic vessels are stretched like that because of backflow. You're gonna have, when we're assessing our patients, we might see an S3 with their heart sounds, because S3 is indicative of fluid volume overload. And again, this objective could be right or left-sided, okay? So you're going to see S3. You're going to see the symptoms, the edema, the this and that and the other, with, the edema, the body symptoms, or the respiratory systems, depending on what kind of heart failure they have. They might have cool extremities this is with both, so cool extremities. with left-sided heart failure, the extremities are cool because they're not getting blood flow, they're not getting oxygenated. With right-sided heart failure, their extremities are cool because of the edema. And you're going to see cyanosis in both because there's not good perfusion. And so the causes of right-sided heart failure, left-sided heart failure. So the causes of right-sided heart failure, the most common is left-sided heart failure. Now there's genetic, that story that I was telling you about with my patient that had that autoimmune disease that I cannot remember the name of. It affected both sides of his heart because it affected muscle tissue. So it could be genetic abnormalities, let's say abnormalities. Left-sided heart failure. So left-sided heart failure, what happens is, remember, left-sided heart failure, we're backflowing into the lungs. And remember how I said at the beginning that the right side is weak, right? So because it's not used to pumping against a lot of pressure, right? So when that blood with left-sided heart failure pumps back or flows back into the pulmonary, it increases the pulmonary vascular resistance, which is also called pulmonary hypertension, okay? And pulmonary hypertension is the most common cause of right-sided heart failure. So left-sided heart failure leads to pulmonary hypertension. Leads to pulmonary hypertension, which leads to right-sided heart failure. Now, pulmonary hypertension is not only caused by left-sided heart failure. It could also be caused, it could also be due to COPD. I've had a patient that was a smoker, so smoking can cause this, those kinds of things. But it's not as common as left-sided heart failure developing into right-sided heart failure. Anyway, so I hope this helps. And here, while I talk, I'll go back to my pretty pictures so that you can see while I finish talking here. But I hope this helps. If it doesn't, if you have any more questions, you have my number, and I'll write it here in case anybody else needs it. And I will be making more videos for the test. So hopefully this helps. If you have any questions, if you need any clarification, if I spelled something wrong, you guys can let me know. All right.